speaker, who's Mark McKinlay. And I'll give you a little bit of background about him. It's a really good background. And then he'll tell us more about what he does. Mark is the director for the Center for Vaccine Equity at the Task Force for Global Health in Decatur. And the programs include Polio Eradication Support Team, the Polio Antivirals Initiative, and the Partnership for Influenza Vaccine Introduction, the Global Founders Consortium for Universal Influenza Vaccine Development, the Coalition for Global Hepatitis Elimination, the Safety Platform for Emergency Vaccines. And prior to that, he was a member of the Polio Antivirus Steering Team since its founding in 2006. And he has some more in his background that's very complex and very interesting. So he received his undergraduate degree from Union College in Schenectady, New York, his master's and doctoral degrees from Rensselaer Polytechnic Institute in Troy, New York, and completed a postdoc research fellowship in molecular virology in the Division of Biophysics at the Johns Hopkins University School of Hygiene and Public Health. So if you welcome Mark.
Thank you. Thank you. Wow. Thank you all very much for the invitation to speak to you today. What I'll say right up front is please raise your hands. A lot I'm going into is maybe a little too technical. I tried to keep it a little away from that, but that's my natural inclination to go in that direction. As Rita just told you, my background, I'm a virologist, which means I study viruses. That's what I was always interested in, how something you can't see can have such an impact. And so I've been working on polio since back in the early 80s. And actually, our team discovered a drug that was the first one to be effective in preventing paralysis and death in mice, and that got me interested in the whole area. So I spent most of my career in the pharmaceutical side and biotech, developing antiviral drugs. But then in 2008, I got invited to participate with the task force on a steering team that I'll tell you about. And that brought me into the global health side of things. And when I was looking in 2012 what I wanted to do for the last phase of my career, the task force invited me to build the Center for Vaccine Equity. So it's been a tremendous opportunity. And as you'll hear, it's allowed us to be involved in all aspects of polio eradication. So the talk today, I'm going to break it into three major parts. First is to give an overview of the task force and sort of how polio fits into what we do. Then tell you where we are with polio eradication, and I think you probably all know it's been a real challenge, as it usually is in the last mile of eradication. And then explain all the areas that the task force is currently involved in with polio. I'll just call your attention to that's an actual polio virus up there, and worked a lot in my early days of my career to understand exactly the structure of the virus and how a drug could be designed to block its replication. So the Task Force for Global Health is based in Decatur. We bought the DeKalb County buildings. We're actually on Leon Avenue over there. We're about 150 folks there. But the task force got started back in 1984 by Dr. Bill Ph.D., who's a legend in the public health area as one of the leaders in the eradication of smallpox. He was also the head of the CDC. And with these different funders, WHO, UNICEF, World Bank, UNDP, Rockefeller Foundation, they were trying to increase vaccination rates from 20% in 1984. They wanted to get up to 90 or 80% by 1990. And all these funders were kind of falling over each other and not doing this in an organized way. And Bill Faggy created a task force, a short-lived operation to get this job done, and they actually did it. Along the way, he was contacted by the CEO of Merck about a drug they had that was active against river blindness that then took the task force in a different direction that I'll tell you about in a second. First of all, has anyone heard of the Task Force for Global Health before I came here? The reason you didn't was that our Bill Ph.D. believed that the focus should be on our partners, not on us. And so that's great until you try to raise money and no one knows who you are. So we're learning that little thing now. But our mission is to eliminate diseases that have plagued mankind forever, and you'll see a slide in a minute that shows that, as well as building the systems that are needed to protect populations. So we don't want to just come in, treat a few people and leave. We want to build the systems that will actually help these countries going forward. We have 14 programs that I'll review, 150 staff. When I started in 2012, there were 60. So, I mean, it's more than doubled since then. And we work in 150 different countries, not just us, but with our partners, global partners around the world. And we have funding from everywhere from CDC to the Gates Foundation, a number of different pharmaceutical companies as well. So the task force is well-funded and well-supported. So what do we do? As I mentioned, Bill Ph.D. brought this group together and built a coalition. That's what we're best at, bringing together groups that don't necessarily agree on how to proceed, like we did this with cholera, because one group thinks, oh, it's all about improving the water, the other group thinks it's all about vaccines. The answer is it's actually about both, so we need to get everyone together and make it happen. So we now have 8 global partnerships, and I'll show you some of those in a minute. We also have a lot of drug donations. So Merck, I mentioned, for river blindness. We have Pfizer donating Zithromax for blinding trachoma. And the total value of the drugs they're donating to us is worth over $2 billion. We also operate and do research to really define what countries can do and make the case for their ministries of health for where they should make investments. Because these countries, particularly the poorer countries, have to really make choices. And they need data to make those choices. Lastly, again, is that it's really important to build the health systems and also to put in place systems that are sustainable going forward. So this summarizes a number of the programs that we work on. So you can see we work on everything from leprosy to lymphatic filariasis or elephantiasis to river blindness. The group in the Center for Vaccine Equity, we work on influenza. We're helping countries build programs so that when the next pandemic comes, they're prepared and they know how to handle the vaccine. We work also on trying to develop an improved influenza vaccine. I'll tell you all about the different things we do in polio eradication. And the newest area that we're working on is viral hepatitis elimination. This is hepatitis B and C elimination. So you can see it's a broad range of things, and we now learn from each group so that we don't work in little silos, but we actually share our lessons learned with each other. So where did the idea that polio could be eradicated come from? It came from actually people who started the task force. You'll see here Bill Ph.D.'s name. I said he started the task force. Alan Hinman, who still works with us as a consultant, he used to be the head of immunization at CDC, as well as Walt Ornstein, who's a professor at Emory, also was the head of immunizations at CDC. They all worked together to put together this paper that said that you can eradicate polio, and if you do it, you could actually have it done by 1995. Well, they were a little ambitious and also didn't know many of the things we learned today. But it all started, interestingly, with the task force. So where were we in 1988? So this is a year after that paper. 350,000 cases of paralytic disease in the world, 30,000 deaths in all these countries, 125 countries. I mean, so look at this, because this is what will happen if we don't finish the job. We're going to go back to something approaching this. But the World Health Assembly, based a lot on some of the arguments made by the task force folks, made a resolution in 1988 that we're going to eradicate polio. And we're going to do it by the year 2000. And of course, when that was stated, they didn't really know about vaccine-derived polioviruses, et cetera. So a lot of the things that were learned along the way came to pass, and why we're still talking about eradicating at this stage of the game. So a number of partners came together, because this cost a lot of money and is taking a lot of resource. And these partners are called the Global Polio Eradication Initiative, or GPEI partners, that involve WHO, CDC, the Gates Foundation. As you well know, Bill Gates and his foundation has put a ton of money into this. The Rotary organization, this has been a high priority for them for a long time. In fact, the person who started this process is on comes to our polio antiviral steering team meeting every year, and UNICEF. So this group came together to provide the resources to make eradication happen. So how have we progressed? So back here is when I was telling you we had 350,000 cases in 125 countries shown there. And this is as of Thursday. There are 94 cases now in 2 countries. So 99.9 something percent. And you can see they're really, even though Nigeria hasn't had a wild polio in a few years, it's still there because they need another year to go by. It's mainly just Afghanistan and Pakistan where the virus is residing. So where are we now? So there are 3 types of polio. Polio 1, 2, and 3. 2 of them are eradicated. They're gone. They're certified. In fact, 2 weeks ago, polio 3 was certified as eradicated. So we got rid of 2 of them. But polio type 1 is still there. And as of Thursday, there were 94 cases in 2 countries. And these 2 countries, Pakistan and Afghanistan. So while we've done an amazing job, we haven't finished the job which we need to do. This is a fact that to me is so impressive, that the number of people, 17 million people, are not paralyzed today because of the work that's been done. So if there's only one number you remember from today, that's the number. Yes, sir?
What are the 3 types of polio?
Polio 1, 2, and 3. So it means if you have immunity to, say, polio type 1, you could still be potentially infected by polio 2. There are different serotypes of polio. So there's only one type still existing in the world. So significant challenges remain. And these are things that you learn as you get closer to the end. The problems that arise. In Pakistan and Afghanistan, there's lots of issues and challenges that we're trying to address, including large unvaccinated populations that aren't always recognized that they even exist, and they're moving across borders. And there's also all this anti-vax type of misinformation that's swirling around, that the Western people are trying to sterilize the Muslim girls, etc. All this kind of stuff. They had a video of this classroom where all the kids were given the vaccine and then they all dropped to the floor, and it went viral. So everyone's thinking the vaccine's causing these. I mean, it's that kind of thing that you have to deal with and address in the plan going forward to avoid the resistance to vaccination. But probably the biggest surprise, and this wasn't known when the World Health Assembly said we will eradicate by 2000, was the circulating of vaccine-derived polioviruses, which are called CVDPV, these outbreaks. So this is the live virus. So Albert Sabin's oral vaccine is a live virus. It's polio, but he passed it in the laboratory, meaning he went from generation to generation until he ended up with a virus that had become attenuated, or that when you put it into a chimp, it didn't cause paralysis. So the problem is, if you let that circulate in an immunized population, the virus can revert back, mutate back to the neurovirulent form that causes paralysis. And that's exactly what's happened. So now you get outbreaks of the vaccine-derived polio in populations that are not immunized. And that's what happened over the last few years. Countries said they had vaccinated, and they didn't. And so, or didn't vaccinate enough, so now you've got all these outbreaks occurring. And of course, they're saying, oh, well, this came from the vaccine, so that then causes a fear of vaccine, because it is a vaccine-derived infection. And as you'll see in a minute, there are more cases of the vaccine-derived polio than the wild polio type 1 that we were talking about. And the most common one is the vaccine-derived polio type 2. So, we obviously have the vaccine to all three types, even though the wild polio type 2 or the 3 are gone. We need people to stay immune in case it ever did come back. And right now, as you'll see, there are outbreaks in nearly 20 countries. And all the GPI partners are actually meeting at the task force next week to develop the strategy for how to deal with this emerging situation with CVDPV2. So this is a map that shows you where what's going on. So in red, you see here Pakistan and Afghanistan. Those are the isolates of wild polio type 1. Then you see in green polio type 2. This is the vaccine-derived CVDPV2. As you can see, there are a number of different countries with that. We also have one in China, and then we also have type 1 vaccine-derived polio in Myanmar and one in Indonesia. We also have cases now of polio, vaccine-derived polio in the Philippines. So this is a real issue, and it's strictly due to the fact that the populations were not vaccinated sufficiently to prevent transmission.
So we don't have that in the United States?
Oh, no, we haven't had polio in the United States, I should check this fact, for a number of years. Now, we've had, you'll see immune deficient type polios, but one of the things we need to do is keep our immunization rates up. So even if someone did come in with it, the population is protected. So, yeah, no, we haven't had wild polio.
But even the CVDPV?
Right.
We haven't had any of that?
Right, no. And even if they came in because of our immunization rates, and I'll talk about that in terms of the containment activities we're doing, which is all around making sure that all states or everyone's keeping their immunization rates up.
But isn't this vaccine-derived polio, that is from the oral polio
Correct.
vaccine, where in the U.S.
We're using the inactivated.
Yes.
And so, well, a good question, and I'll get to that in 1 second.
Okay, that's fine.
In fact, right here, there's Jonas Salk. Okay, so the possible solutions here is, number one, set up environmental surveillance, sewage systems, et cetera. Because this is a fecal oral spread virus, if you're looking in the sewage, that's where you're going to find the virus. And even if you haven't seen cases of paralytic disease, if you see it there, you know you have to start vaccinating. So this has really been ramped up a lot, thanks to the GPI partners pushing. And also, there's a huge effort underway, and the new strategic plan really focuses on reaching all the children with vaccine. There's also a move to using and switching, like the US switch to the inactivated, because of the few cases of vaccine-associated paralytic polio that happens. There were only, I think, 6 or 8 that were happening a year, but the CDC, et cetera, decided no, that was too many, let's switch to the inactivated. So this is killed. It's killed, it won't grow. It definitely induces protective immunity, but it doesn't induce immunity in your gut, so it doesn't prevent the virus from replicating. So if you are vaccinated with IPV, the inactivated, and then get exposed to polio, it can replicate in your gut and you can excrete it. So that's why this is a bit of a challenge. You can protect the population from paralysis, but not of the virus circulating. One of the ways around all this that's really helpful, because remember, one of the great things about the oral is it's drops. Anybody, you don't need to be trained in giving an injection, is to make a safer vaccine. So the GPI partners are working, and they have one. It's amazing. It doesn't revert back to that paralytic form. but it's still oral. And we're hoping that it can be released for use in early 2020. So this has been a real priority for everyone. But because you can never tell when these things get approved, we have to have a plan B. So they're working on plan B, C, and D as well. So there's a new polio endgame strategy because when all these vaccine-derived polios were coming out, they said, okay, we're going to have to extend the timeline. We have to get this job done. This is not a matter of science. It's a matter of delivering vaccine, period. And there is no reason why there should be polio. I mean, we have all the tools. We just need to make sure we're getting the population vaccinated. So the new plan is to stop transmission of polio type 1, as well as these circulating vaccine-derived polios, and then strengthen the immunization systems, not just for polio, but for all the different vaccine-preventable diseases. And then, as I'll talk about containment, make sure you know where the viruses are, because once you think you've eradicated, if it's sitting in somebody's freezer and they bring it out and start exposing people, you can have it come back. So this, you'll see, is a huge effort underway to track down every vial of poliovirus in everybody's freezer. And it's an unbelievable amount of work, and we're involved in that, I can tell you. It's pretty incredible. So the key elements of this new plan is to really build a hub in Pakistan and Afghanistan and bring together the different technical and capacities needed to build and respond to the need to increase vaccination, as well as partner with different groups like the civil society organizations within the country, engage like the women in like in Pakistan. The women in the towns will go with the vaccinators to help and say, it's okay if your daughter gets vaccinated. This is not, what you read is not true, et cetera, et cetera. This is the kind of thing that has to happen in order to keep the vaccination rates high enough. Also, building response teams to go into these countries and provide the resource that's needed to get the job done, because we've got to vaccinate a large population. And as you hear, the task force has one of these teams that we've put together, supported by CDC, to go into countries and help them manage the process. So now I'm going to kind of go over the 4 major objectives that the Global Polio Eradication Initiative partners had, starting with polio detection and interruption, removal of the oral polio vaccine type 2, and I'll explain more about that in a minute, and strengthening immunization, introducing the inactivated, containment, and then planning for when polio is eradicated. So the task force has been involved in all 4 aspects of these things, and it'll be hopefully illustrative for you to hear our role. So, as I mentioned, the oral vaccine that Albert Sabin, shown up there, developed, which was a game changer, because you don't need to have a trained person to vaccinate. So it's alive, attenuated, weakened, it's easy to deliver, it grows in your gut, just like regular polio, so it induces that immunity I said is so critical to stop transmission. And over 10 billion doses have been administered. But the problem we talked about, it can go back to a paralytic form. The other thing that was learned over the last 20 years is that individuals who don't make antibodies can't clear the virus very well. And 1% of them can continue to excrete this virus, and that can cause paralysis in them as well as transmission to others. And this is where I got involved back in 2008. So, I mean, depending on your immune deficiency, there's a fellow in Birmingham, England, who is this is a few years old now, so it's like over 30 years he's been excreting all 3 types of poliovirus. And so it's an issue because, number one, he will, any day he could develop paralysis. but he also can infect others. So we need to identify these individuals and treat them with the antivirals that we're developing at the task force. So, as I mentioned,
Excuse me, so
Yes,
somebody
yes.
like him who is growing the virus in his gut, would it, the injectable vaccine work on him or not?
no, because he doesn't make antibodies.
Or he does make, yeah.
So the only way you can stop this is with an antiviral drug.
Got it.
So that's where I got a call from CDC back in 2007, I think it was, to get together National Academy of Sciences with WHO, et cetera, and say, can we develop an antiviral drug or two? And if so, is there value in doing that? How much value, and who's going to pay for it? So Gates was there, CDC was there, et cetera, and the answer was we need to do it. And that created the Polio Antivirals Initiative. And this is what brought me. I was asked to be on the steering team and came to join the group back in 2008. The cover of our report, you can see the first case known of paralytic disease back in the Egyptian times with one of the princes with a leg and a cane. So clearly this virus has been with us for a very long time. So what are we doing with this group? We bring together the sponsors, the companies, and we work with big and small. Now we're down to a company that's so small it's only 3 people. And that are developing these drugs. And we take the funding from our funders and help the company develop these drugs. And so this is a little lesson in virology. I don't know if you can see it here, but the drugs that we're developing target just viral proteins. They don't affect your other proteins in your body. And because of that, they're very safe. But they do go back to develop resistance mutations that to avoid the drug, and I'll talk more about that in a minute. So we have 2 different drugs. Because of this resistance problem, it's known that if you develop, from HIV they know this, if you develop drugs that work by 2 different mechanisms, the probability of resistance development now goes down by orders of magnitude. So we're working on 2 different approaches. This one is related to the drug that we discovered back in the early 80s. It binds to the drug, the virus. When the virus enters the cell and starts to uncoat or release the infectious material, this drug acts like a glue, like preventing that from falling apart. So the virus never releases the RNA, and it's totally stopped. So the infection stopped right there. The other drug, once the virus makes this protein, its own protein, and it needs to be chopped up, there's a protein that the virus makes. This drug inhibits that specific protein. So they can't make the proteins to assemble into new viruses to be released. So these are the 2 drugs that we're working on. And so I'm sure you're interested in the actual chemical structure of these compounds. But anyway, these compounds were developed by big companies. They since decided they weren't interested. They were developing them for the common cold, which is related to rhino, which is a long story. But so this small company licensed these 2 drugs. They're developing both drugs, and the idea is to combine them into this drug that'll be called Virology 7000, both drugs together. So why do that? Well, first of all, these drugs work very well. They're very potent. They work against all the polios, but 1 in 10,000 viruses will become resistant to the drug for each one. But if you put the 2 together, now it goes up to 1 in 100 million. So 4 orders of magnitude lower resistance. So this is why you need to have the 2 drugs together. The other thing is, you put the 2 together, you get 1 + 1 = 5 in terms of activity, because they're synergistic. And so this is the reason why we're totally focused on developing 2 drugs. This just shows you the polio viruses here, the sensitivity. It shows you that bocapavir, that lower means more sensitive to the drug, higher, and you can see that they're all quite sensitive with a few outliers. So all the polios are sensitive to both drugs. So what we had to do with the first drug, bocapavir, was we knew that it worked in mice. Want to see would it work in humans. So we went to Sweden. We got a group of folks that consented to be in a trial where they had to stay in a hotel for a period of time until they stopped excretion. They were all individuals who were vaccinated with the inactivated as a kid, so they're protected. And they were given type 1 oral vaccine, so the live vaccine, and we tracked how much virus they excreted over time, and they were let out of the unit once they stopped excreting. And we gave them bocapavir or we gave them a placebo, and we compared the two. And what that study showed, very convincingly, here are the number of days post-infection, and here's the first day, each block is when they stopped virus excretion. So the placebo started one on day 7 and a bunch mostly on day 9. The drug treated, we had a huge number that stopped excreting before the placebos, and then the rest later on. But what we did see with one drug, the R's mean resistant virus development. So we definitely had resistant virus develop, and also because they're all contained in this room, they were transmitting it to each other. So it wasn't all originating in individual patients, but they were transmitting it. But this made the point. The drug works, it's safe, but it can develop resistance if you're talking about a single agent. And these are immune competent individuals. So what have we done at the task force? So in addition to developing these antivirals, with the WHO and the Gates Foundation, we set up a study around in 13 different countries around the world in areas with high immune deficiency rates to see what's the rate of this excretion. And we found that 1 out of 100, or 1% of the individuals are excreting the virus. So now we're trying to track down how are we going to find them and treat them with our drug. So that's going on, that work, that's underway. As I showed you, we've demonstrated that the antiviral can work in a human, and we are now treating with bocapavir excreters that contact the company on a compassionate use basis. In some cases, they totally stopped excretion on the second day of treatment in individuals that have been excreting for prolonged periods. In others, they stopped excretion of the sensitive virus, but continued to excrete resistant virus. So making the point that we need both drugs. So that's why the company is continuing to advance these two drugs forward. Okay, so as I mentioned, one of the other things for this objective 1 is providing support to basically stop these outbreaks that are happening. So we put together a surge team. We have 3 senior epidemiologists that are now in various countries, and they're providing the additional resource that will help work with partners to implement the solutions that are needed. And we just had a training last week at the task force for 3 days of another 60 folks that are going to be going out into these countries. So this is really, really key to have this sort of structured long-term deployments to provide the resources that these countries just don't have. So the other area we worked in is this whole idea of withdrawal of the least safe vaccine and introducing the inactivated. So first of all, the inactivated. The idea is everyone needs to be vaccinated, so they either get the oral or they get the inactivated. So we wanted to switch more countries to the inactivated to avoid this problem. And so we got 90% of the countries there using the inactivated. We also wanted to take the live vaccine that had all 3 types and get rid of type 2 polio, because that one is the most associated with this vaccine-associated paralytic polio. So we wanted to get rid of it. It was providing too much risk. But in order to do it, we had to have the whole world, 155 countries, switch from the one that had 3 types to the one that had 2 types. And we had a team that helped with that whole unprecedented operation. And the head of polio for WHO, when he came to the task force, said that it could not have been done without our team. So it's really been a challenge. Of course, the assumption here was that these countries had vaccinated their populations well before we made the switch, and turning out that probably wasn't the case. We captured all the lessons and published in the Journal of Infectious Disease, prestigious journal, all the lessons learned from this unprecedented work. Containment. Remember I mentioned containment. Once you've eradicated, you need to also contain. So right now, assuming we're going to eradicate, we're putting in place all that's needed to contain. So that means either you destroy the virus, first you got to find it, then destroy it, transfer it to an essential facility, and there's very well described what that is. And if you become one of those few essential facilities, like CDC is one of them, those places know how to work under high containment whenever they work with the polio virus. So what the task force was asked to do was to serve as the secretariat for the United States Certification Committee. So we convene this group. They prepare all the reports. They review the CDC data and provide the reports to the regional certification group. So this is really key going forward. And basically every freezer in the U.S. has been checked in terms of its whether or not they have polio, and all that virus has been destroyed or moved to an essential facility. Last but not least is legacy and transition planning. So one of the things here is that as countries move, a lot of their medical budget is coming from polio. Like Somalia, I think it was 100% of their health budget was from polio. So when polio money stops, what are you going to do? So we, with support from the Gates Foundation, et cetera, helped to put together plans for these countries and how they were going to manage the transition. And so we did that over the period of 2016 to 2018. So hopefully that gives you a sense that we've been involved in various aspects of polio eradication, and gives you a sense of the complexity of the issues that we're dealing with in terms of eradication. And really, there is no option, but we have to finish this job. And that is the key point, and leave you with, again, that 17 million people that are not paralyzed today. If we don't succeed, we will be right back to that curve that you saw with the number of people. Within a decade, the modeling shows, we'll be back to 200,000 cases of paralytic polio. And the cost that countries will have to incur to deal with that is just enormous. So, I mean, it's a no-brainer in terms of the cost effectiveness of doing this, but that, of course, is not even a challenge. And also, of course, this threatens other immunization programs because you're taking away resources from them. So we cannot fail, and as I'm sure you've seen, we're this close and we have to finish the job. So thank you for your attention. I'm happy to answer any questions. Yes?
Many years ago, I was told if you had vulvar polio, which I assume is one of the 3 strains.
Right.
I believe I was told that, well,
Yeah, you're on. Yes. Yeah, I can hear. Yep.
that you were immune to the other 2 forms. Now you're saying that you are not immune except to the 1 form that you had. Is that correct?
Right. You're only infected with 1 type when you develop. Right. Correct. Now, I'm not an MD, so in terms of the cross, I mean, that's the definition of polio 1, 2, and 3 is whether antibodies to one inhibit the other. So that's sort of the inherent definition. But let me check on that just to be sure. That's my understanding.
Thank you.
I
Yes,
am
Rena?
wondering if you, if any way this virus is related to the AFM virus that the little kids are getting?
Right.
And if you
So
know
that was
anything
one of the
about it.
questions. There was some concern, could that be polio? And
Yeah.
of course it isn't. But it's a related enterovirus. It looks like it's not 100%. Enterovirus D68 is the top candidate. But there's still a lot of debate whether or not it is that, because they don't find it in the central nervous system of the kids with AFM. So, but that's the betting money, is that it behaves like an enterovirus. It's clearly not polio, but it looks like it's a enterovirus. But like I say, there's still a pretty strong debate as to what's causing it.
Anybody else have any questions?
What about the people who are anti-vaccination? The ones in Hollywood and all the rest of them that don't believe in any vaccination because it causes autism.
Okay, so this is a real threat, as I mentioned here, to not only polio, but flu, you name it. So number one, the autism claim was clearly discounted years ago. He lost his medical license, et cetera, but he's still going around talking. It's a real challenge. We have a group at the Task Force for Voices for Vaccine. It's a parent-led organization that is helping parents hear from other parents what the real facts are. And it seems to be more effective than hearing it from their doctor. But you're right on. I mean, you look at countries like Ukraine where, look at the measles outbreak this past year, because they're totally anti-vax. So this is a huge issue and one that no one's come up with a great solution. We think this parent approach seems to be working pretty well. Like I say, for whatever reason, other parents listen to parents before they listen to their doctors, so maybe that will help. But all in all, one of the talks I heard, an expert on this said, there's only a few that are really hardcore anti-vax. Then there's a group that's got questions, because they're worried. They hear, oh, this can hurt my kid. Well, everyone would be concerned. They want to know the facts. If you give them the facts, they'll vaccinate. So that's the group we're focusing on, because the hardcore, you're never going to get to them. Just focus on the bigger group that are the ones that are looking for answers and provide those answers.
Thank you.
I'm wondering, you have a laboratory, or are you strictly?
No, we have no laboratory. I did back when I was in pharma. We had a laboratory where we assayed I grew polio all the time. I used to grow it in mice, etc. But no, not at the task force. We don't have any laboratories.
Okay, so then CDC does all the laboratory?
Oh, yes,
Yeah.
exactly, right. Yes.
That brings up another question. Didn't I hear that they were using the polio virus to insert chemicals into the body, into the brain?
So they're using poliovirus as a mutated poliovirus to treat a brain tumor. Right, that's a group at Duke, I think, if I recall correctly. Yeah, it was some pretty impressive results, but it's not polio that I don't want to get beyond my knowledge of it. I'll have to go and check, but I don't think it's a virus that can replicate outside the hospital setting.
And it's not paralytic.
I need to double check. I'm pretty sure it was altered virus, but I need to check on that.
Thanks.
Yes.
I keep thinking of that 1% that produce antibodies. Don't produce antibodies.
Mm-hmm.
So 1% of our population walking around excreting this virus.
No, it's 1% of those people that are B cell deficient. So that's already a pretty low percent.
Okay.
But in some countries, like in countries where cousins can marry, et cetera, the frequency of immune deficiencies is much higher, like in the Middle East, et cetera, Pakistan. Those countries have a much higher rate of immune deficiency and therefore a much higher rate of this. So it's 1%
Okay.
of those folks, right?
So that explains why we're not getting the virus here,
Right.
even though
Well,
we
there
have
were,
these people.
you know,
working
we
here.
actually were trying to track down some folks that were in this country that had that virus so that we could treat them and offer, treatment. The last case I know documented here in the U.S. was a mother in Wisconsin who had been infected when her child 11 years earlier had been exposed to the oral. That's when we were still using the oral. She knew she was immune deficient, but didn't know she was excreting polio, and it ended up, she developed a very severe case and died from it. And it just shows you the kind of thing. So that's why now we want to go out. We're developing, with Gates' help, a rapid diagnostic. So if you have frequent infections, all the sort of signs, the Jeffrey Modell Foundation signs of immune deficiency, you get a finger stick test that says, it looks like you have very low antibodies. Then go to your doctor. If you do, then take a stool sample and look for polio. So that's the approach that's going to be taken. Because we have to find these individuals and treat them.
That's not routinely done.
Uh,
You have to ask your doctor.
Right, and again, we're trying, right, but, so, I don't know if you've ever seen these signs around, like at the airport, the Jeffrey Modell Foundation, Immune Deficiency Foundation. They have, it's like 10 warning signs, and so, and it's frequent. I mean, you would know it, anyone here would know it, but the problem is in countries where low income, et cetera, they have chronic diarrhea and all these things already. It's hard to know what's, you're in that category.
Or
So
did you
that's
just
why.
drink bad water?
Right. So that's the reason why we're trying to have this test, because what they did in Egypt, they did a study and they found that they were only right when they used a questionnaire 1 out of 20 times. That means you're testing stools on 19 kids when you only need to test for 1. So that's what we're working on.
I'm not familiar with that. I'll have to Google that one then.
Jeffrey Modell Foundation? Yeah, they worked with us on this survey that we did in the 13 countries. Yeah.
Good.
Any other questions?
Well, thank you, those are great questions.
Well, I'd like to thank you, and
Pleasure.
this has been just outstanding wealth of information, and all your information that you gave us in written form.
Right.
And I'm certainly glad I found you on the internet.
Yes, well, thank you. Yes, that's right. It took a little while.
Yeah, I was in that, I'm looking for that task force, because I
Right.
happened to see it, because I
Right.
worked in healthcare. And then I thought of this, because people had asked me to find a program where we could get more information on polio worldwide and, things
Right.
like that. So anyway, we certainly appreciate
Great.
you coming to us.
Okay,
Glad there are
great.
people like you fighting the fight.
Yeah,
for us.
I know it, and all the things you're doing behind the scene, I was
Yeah.
just looking at all that, it's very impressive.
Right.
And your background is very impressive,
Well,
so
thank
we're
you.
expecting.
Yeah, the annual report gives you a little
Yeah.
sense of the different things that our group works with. Yeah. so
Well,
appreciate
thank you then
Yes.
so much.
Well, thank you all for your interest. Thank you.
Mhm. Let's see, we'll start with what Carol gave me here. She wants to remind you that Georgia Gives, begins November 1st. And, let's see what I've got here. Well, I have on here that the annual day of giving is December 3rd. And it's, something that apparently has raised millions of dollars when they first started this.
It's usually the Tuesday after.
Yeah, it's the Tuesday, so. And then she's got our elections, and of course ballots were sent out to all the members this week. And you mark the ballots and return, and you said we got quite a few returns now, so that's good. And then, of course, December 7th is Apple's Christmas luncheon at Vargiano's Little Italy. and it's gonna begin at 11, and we have to be out by 2. And of course, I'll have my, my quilt that I've made. It's a table topper, and that one is gonna be available by ticket. You buy $1 for 1 ticket, and 6 tickets for $5. And then this would, instead of just a giveaway to anybody, it would be for somebody who's, interested in having that kind of thing. And then it raises a little bit of money. It isn't gonna be a lot, because I didn't want people to spend a lot and be a big thing, because everything is so expensive now. And I just wanted to give that to somebody. And let's see. And of course, November 11th is our salute to polio survivors and their family, and to those who survived. And also Thanksgiving is the 28th. Then I have a few other things here.
Rita, when are the election results be announced?
You know what, she didn't say actually. Well, I presume we will have kind of an announcement sort of at our Christmas party.
Usually we do it here.
Yeah,
Right.
we usually do it here.
Yeah, like right
I-
now. Yeah.
Why don't we count the ballots right now?
Well, I guess we count the ballots.
All right, ladies, you're up.
Counters,
Counters.
I nominate Charlotte. Hope she's not carrying it.
Charlotte, what is the name of the meeting?
I'll never remember that.
Say
Oh,
it
no,
again.
she's gonna say it.
Maybe I'm not.
I'll make, I'll say something.
Rita, Harold just knows.
I'm just not loud.
Oh, good. Oh, perfect. Just in time. We're grateful if she can come because of all the circumstances that she has to endure.
Again, I'm Charlotte, the chair of the nominating committee, and we have received all the ones from the mail, and we have looked at them, and everyone accepted the slate. It's been unanimous that all 3 names were accepted. So all in.
So, but who are the names of the people that it's,
Billy Pond, Wayne Nichols, and Belinda Whitaker.
okay, well, good. We're grateful that you will join us, and we look forward to a nice year next year. I have a few things that I just want to say. Remember when Georgia Cares came and Shirley Thomas talked to us, talking about costs of hospital visits were to be posted on the internet? Well, wrong. A judge put a block to the Trump administration doing that on the internet, so that's on a hold position. And Shirley wanted me to tell you all. Let's see. It says here, this month, 5 federal courts temporarily blocked a Trump administration final that would greatly harm families and prevent people with Medicare from accessing the services and supports they need to thrive. The new public charge policy was set to become effective on October 15, but the recently issued nationwide injunctions will prohibit the rule from taking effect for now. So, and then she gave me a website that you can check that if you're interested. Let's see, and then I have a little notice. This is from the Polio Heroes of Tennessee, and it says on the Johns Hopkins University research study, AFM and polio. And here it says, a new study concerning AFM and polio is being conducted by researchers at Johns Hopkins. The objective of the study is described as follows. We are trying to understand why some people get better quickly after an infection and others may have breathing problems and still others have neurological symptoms of paralysis. We would like to compare the cells and DNA of persons with severe symptoms with those who've been exposed to the same virus but did not have the same outcomes. We plan to compare the DNA sequence of people with paralytic poliomyelitis to DNA sequence of people with AFM following a viral infection diagnosed from 2012 to present. And of course, they're looking for genetic variants that both groups share that can help why a virus can cause mild symptoms in some people, respiratory or non-paralytic polio, but severe outcomes like paralysis and others that you've experienced. So I thought that might be kind of good for you to know because of this AFM. And then, of course, our holiday party. And if you all want to come, you submit your money to our polio, our post office. Let me see if I got it here. Okay, it's to the Post Office Box 245, Cumming, Georgia 30028. And then if you send me an email or you can call me that you're coming, because I have to have a head count, and we can have no more than 60 people. But it's for our gift for the poinsettia.
Okay, I'm confused, is there not an invitation going?
Yeah, the invitations are coming out. I'm just telling you to be aware of that and kind
So
of.
in addition to the invitation, we need to email you?
So usually what happens, the invitations go back to you. They used to go to Cheryl, and Cheryl would collect all the money and the head count and everything.
Oh, well.
And then at the party, she and I would get together, she'd give me the monies, I'd pay the restaurant, I'd pay her for whatever her expenses were.
Well, it was decided that all the checks will go to the post office box. And then I will get your telephone call or an email saying that you're coming and how many guests you're bringing.
Will that be?
Yeah, you get an invitation.
But it will be specified on
Yeah, oh
the
yeah.
invitation?
I'm just telling you so that you're
To
aware.
call you or let you know,
Yeah, but-
RSVP to you.
Yeah, the RSVP to me, because I'll need a head count for poinsettias or whatever, and I gotta be sure there's no more than 60. I don't think there's gonna be.
We've never had
I
more
know
than-
it,
We've
but-
never had 40.
Well, then that's fine. I mean, I just have to have because of the gifts. But apparently, it's $22 for you all, and then I was informed that it's $22 for a guest, your first guest, and after that is $30, which I thought it was $30, but I was misinformed. But anyway, the money will be collected, and there's another way, if you want to do through that Cash App, that you could work with you and the money gets in, because some people don't have,
No,
No?
don't bring anything else into it, please.
All right, that's fine then. You'll have to write a check and somehow get it to the to your post office box. Anyway, other than that, we hope that we see you. It's from 11 to 2, and it's December 7th, and I can't think of anything else. We're going to have a little music program, and so it'll be kind of fun to get together. And when you come into the restaurant, it just smells really good. It gets you into the mood.
It's on the room that we're gonna be in is on the second
Yeah.
floor, but there is an elevator.
And I'll be down running around and stuff, so you'll see me and I'll direct you. So we're hoping that, you all come and maybe bring a guest and, just have a nice fine time for the holidays. And I'll have 2 gifts per table that will be just kind of by luck that you get to have it. And so if do you have any questions you want to ask me?
So
Anyway, the invitations are coming, so I'm just alerting.
Good.
Yeah, they will.
next week or two, get the invitation.
Yeah, it should be. I mean, she's had it now for a while. It takes her, she's a volunteer, so it'll take her a while with the mail system and all this. Okay, since our president is now here, would you like to add anything, Carol? Yeah, would you like to add any information at all?
Hello, everyone. It's good to see your faces today. Sorry, sir, that I missed you, but I'll be sure to see it online and go back and see. As you know, we tape, so thank you. I can never predict my time these days. As most of you know, I'm the main caregiver for my mom. So, thank you for all being here. Did you talk about Georgia Gibbs?
I did slightly, but not like you, like I should.
Okay.
I mean, I'm not as knowledgeable about it as you are, so if you
Okay,
want.
usually I have a lot more out by this time, but as you notice, whenever I do get a chance to get to my computer, it's hard because I'm there for a few seconds and I have to jump up and take care of something and then go back and that kind of thing. So to all of those, did you announce the results of the election?
Yeah, she did.
Okay. And congratulations to those on the ballot who were elected. Georgia Gibbs is the first Tuesday after the Thanksgiving holiday. And we would like you to share the information about Georgia Gibbs with your friends and family. I will be sending out a notice for that. As I said, I'm not at my computer as much as I have been, and when I'm there, I can make a mistake or two. So just bear with me as I go through this process. But please participate in Georgia Gives. This is for your friends and family and community and neighbors to have an opportunity to support ALPA. And I hope that you do that. We had a good results. A lot of people were surprised last year to see family members and friends that supported this activity. So we're doing that again this year, and it'll be a very simple process. And you can go online to Georgia Gives and look at that on the website. The page is for APA, and you just follow the prompts there for donating to APA. Okay, and so we have Georgia Gives. That's December the 2nd, is it? The first Tuesday in December?
I thought it was the 3rd, is it?
And you can give any time during the month, actually any time during the year, but the campaign is during the month. And so those proceeds will go to APA, less the administrative fee that Click and Pledge charges. So the first Tuesday is the 3rd of December, because Thanksgiving is late this year. It's the 28th of November. It's the last Thursday. So make sure to mark your calendars, and you can give already at any time, beginning the 1st of this month. Any questions about any activities or things that we have going on?
Oh, in February, we're having Dr. Mark Pollack, and he's a pulmonary doctor, and he's going to tell us about sleep apnea. So that ought to be interesting. And he's very impressive also. He's on a number of the hospital. I mean, he can practice at any of the hospitals around here. There's a number of them in the metro area.
Right.
Yeah, and he's confirmed already, so I feel fortunate to have him also.
Yes.
Yeah, this is our February.
We don't have a meeting in January.
We don't have a meeting in January.
January is board meeting.
Boards, yeah.
Board meets in January. And so that'll be an actual on-site board meeting. It will be here, and that has to be confirmed. What else do we have going on? Okay. What's new around the organization? What's going on with each of you?
Anybody have any comments that is helpful for others, or
Any activities going
Yeah.
on?
or maybe some
Anybody
of the
going
things you're
away
getting
out of
ready for
town?
the holidays?
I understand that Rita brought her quilt at the last meeting.
Yeah, I did.
I thank Rita for that donation to our group. She's a beautiful quilter, and that was a big deal to do that. So thank you very much for that donation, Rita.
Also, the pieces that are gonna be on the tables at the restaurant
Right.
are, it's a quilt block, but it's a tree, and it's specifically for the holidays. So you can take it home and, you know, enjoy it for yourself and do whatever, instead of some of the other things that are not that great. And it was fun to make, and I enjoy doing this. I usually do something like this for somebody, and then I thought, well, this year, since I programmed, I'll do, you know, this for somebody that would like to have one at our group. And, you know, and then you can save it every year and bring it out for the holidays. It's fun to do.
Thank you. We really appreciate that so much. Thank you. So no personal family stories? Joe, you don't have a cat story? You usually have great cat stories.
I've got a suggestion for February. Anybody that's on CPAP should wear their CPAP mask to the meeting.
Not
I told you Joe has a good
I know
cat story every time.
I've got a couple extras I can bring in case you're not on.
Thank you, Joe. That's very helpful.
Guy stands up there looking out at the crowd going, what the hell?
How long have you had sleep apnea?
I was diagnosed about 12 years ago, about the time I joined that.
Oh,
Mine is central nervous related, not, well, typically people that are overweight weight causes flat down. There's two kinds of apnea. The other kind is tied together with polio. Central
for
nervous.
heaven's sakes.
Well, everybody should have a sleep study.
Anybody else?
How about, how many people are dealing with pain management in some aspect or another? Anybody dealing with pain management? No? Okay, wait, okay. Most of you, who has had any pain issues in the past that they've had to resolve? Okay. If you have or haven't, I was thinking this might be a nice topic for a future meeting, if it's of interest to people. I know I'm dealing quite a bit with pain issues right now, and to the degree that I know it took a while to get someone who would talk to us about sleep apnea and a number of sleep issues. Pain issues may be something that people are interested in talking about and hearing about also, so we might consider that for our future.
Well, anybody that has suggestions for a program, please let me know, and, you know, I will eventually find somebody. It took me a while to find our speaker, but I succeeded, so, you know, anything that comes up and you're interested, please let me know. I'll be glad to help.
Okay. Any other news? I'm not gonna just try to keep you here until
I'm
3 o'clock.
gonna make a
Shannon.
suggestion, a
Yes.
reminder. I know this in my heart not to overdo, but I don't always listen to myself. Now that I'm not working and I'm on silver sneakers, I've been doing all these really fun exercise classes till I could barely walk. So, remember, pace yourself, don't damage your nerves anymore. Go have fun, don't see how high you can jump up and down and, you know, lift your legs and all that stuff. Just take it easy. Be
Has
careful.
that created like a pain issue for you?
My damage is in my right leg, and I start limping, and I get fasciculations, and the nerves going tick, 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 and just this weird feeling of weakness and fatigue. Of course, the fatigue.
That's
Kicks
interesting
in as
because
well.
I was doing pretty much the same thing in terms of exercising. I'd go work out and, you know, I figure how much can I do? I'd stay at the gym for an hour or,
Yeah, that's
you know.
dumb. Yeah,
And-
don't do that.
And that's what I was doing.
No, I'm just dumb too. I know. That's what yeah. Just remember to use your
Exactly.
common sense.
And on the machines, I
Yeah.
work out on the machines and all of that.
Yeah,
And then I found I should be doing the opposite
right.
of what was required or what they give other people. And what I found is that the people in the gym, they need educated also, because they really, I was talking to my doctor, one of them recently, about my back. And he's a young doctor and he's really sharp and very good and everything. But he talked about my spine issues like it's separate from the rest of the issues associated with post-polio. And I felt after I left there, I had a great deal of concern because I didn't know that he really understood all that was connected to. So if you do major surgery, that's not going to just solve one thing. It's going to create a lot of other things. So, I just, wonder, there's so much that we can share with other people that is really, really important to get this information out to the community. And I was in to see Dr. Strasser also this past week. He said, Carol, I need more brochures. He's given them all away. So we want to make sure you have brochures also that you can share with people in the community about polio, but polio survivors. But, he had a person in there from Stone Mountain who'd never heard of APA, polio survivor, and I had a chance to speak with her a little. But I have a feeling that it's all over like this. There's just a lot of untapped people and a lot of people in denial that they don't need the services that can be provided to us also. So, I think keeping these things in mind, I'm really glad you brought up about the exercise though. 'Cause I know I was like, cool, I can do this. I take a Pilates class and go to the exercise class and do all of these things and
That's what Dr. Bruno says in his book. Don't overdo your exercise.
Right.
But I was having fun.
Oh.
Yes, I was too. I was having fun too. But the other thing that I found on top of all of this, and one of the other concerns that I have, is the fatigue is real.
Yeah.
And people don't understand that fatigue. They just feel like you're like, you're just, maybe it's lazy, maybe it's you're just a complainer, or they just don't understand that is so real. Yes, sir.
Is it whole body fatigue or muscle fatigue?
It's actually both.
Yes.
It's actually both. It's been my experience. I don't know with others. I find that I would come in from a meeting like we're having today, or church, or just going out shopping, especially grocery shopping. And after I put everything away, I had to sit down. And when I sit down, I'm out like a light, So that's a whole body type of thing. But also that when we're working out or exercising, I'll do a leg lift, and by the time I get to 4,
Or there's brain fatigue
yes.
as well, where your brain just kind of shuts down and gets foggy.
Mhm. And so I just feel when we have an opportunity to share this kind of information, we figure, so-and-so knows that already. But maybe there's something different that they hear.
I know not to overdo. I've been dealing with the post-polio for, going on 30 years.
Yes.
I just need a reminder.
It is, and we need that.
Let me upside my
And we
head.
need that.
Does anybody suffer from extreme coldness in their legs? I mean, there's a point where I can be laying down and I have to be wrapped up in a heating clad and everything else, and it can go on for all day.
Yeah.
What do you do for it?
Every night, I put a warm wrap on my leg while I'm sitting there. I elevate my legs as much as possible. I wear support stockings, I wear wool socks, and then every night I have, it's actually a lower lumbar heat wrap that can wrap around me, but heat that up and just wrap it around my leg until my leg is warm, so that when I go to bed, my feet and legs are warm.
And if you're like, I can't sleep when I'm cold. I can't sleep when I'm cold, so I have to, if I don't do something like what Barbara's talking about, then when I get in bed and say, oh, my leg is so cold, the one leg is like an ice cube. And I have a sock that's like a mitten. It's like a boot type sock that I got. In fact, we talked about this at one time too. What we can do to keep our legs or arms warm, you know, when we're going through this cold intolerance feeling. It's so real, and I get so cold. I get so cold.
Well, do you find, I know with me, I feel so cold, but if I touch my leg, it doesn't feel cold to the touch. It's inside that's so cold.
Mine feels
Is that
cold
how
to
you
the
feel?
touch and inside.
Mine's cold outside, inside, all the way through. And I mean, my leg is cold from the middle of October to the middle of May.
Thank you. Me too.
And years ago, I used to have my annual physical in the winter time, and my physician was always worried that I had a blood clot because my leg was so cold. And so now I make sure before the physician comes in, I'm rubbing my leg.
So your leg is actually white, more
It's
white than
purple.
Purple. Oh, it's purple.
It's, yeah, purple. But I have a very strong pulse in my foot, but there's just, and my feet do swell, and I do wear support stockings, and anyway, I did have a vascular study at one point, and I did not have a blood clot. But yeah.
Is this something that's gotten worse?
Well, probably a little bit. That it's been a problem since I've been an adult.
But for myself, as far as keeping warm, I have an electric mattress pad, and I turn that on and crank it up before I get in the bed.
That will help
And
too.
then it just, I feel like I'm happy. I don't have to turn the heat on in the house or anything like that. It's great.
But what
That's
about
a good
during the
point.
day? I mean, my leg's so
I
cold.
use a Therma-4 heating pad. It's about this big. I got this thing back when I was first diagnosed with post-polio, almost 30 years ago. This thing's still going strong. It is so much better than a regular heating pad. It absorbs the moisture from the air, so it's moist heat. This thing gets so hot, you can't just turn it on because they don't want you falling asleep on it. You have to hold the little lever down. So I'm sitting there on my couch with this thing, and then it's kind of hot, so I let go of the thing, and then a few minutes more. So that's what you could use during the day.
And where do you get that?
At the drugstore.
Yes.
It's not anything.
They have those.
I have one also.
They're big.
Yeah, they're big.
Like this, but they now have them where you can set the temperature limit, like you can set it at Fahrenheit or Celsius. You can set up and lower limits, and you can set the time you want it, because I have.
Mine's
have,
antique.
About this big of a blister on my back one time, when that kind I fell asleep on. So now, I have had that for a long time. I think I got one at the drugstore, but I bet Amazon has them too.
Yeah.
they're called?
Digital.
Thermo-4.
They're digital, and it's the same idea, it's the same thing, they're wet dry thing, and it really, it's like the love of my life.
Yeah,
We all love
really.
that, don't we? Isn't that awful?
Got mine down at Warm Springs, yeah.
That's really helpful. I can tell you that that boot is helpful too, because you can wear it during the day. It has skid-proof bottoms that you can use it like a slipper around the So that's really helpful too. But those thermal, I have that also, and that's really, really helpful. You do have to hold it though. You know, it'll cut off on its own. But there were a number of different clothing articles that we talked about that are helpful to people when you're really, really cold. And we tend to be cold easily. That's one of the things that, you know, we just constantly address. And so sharing that information, it might be good to even post that again or put it on the website. Those kinds of things that are helpful to
I was
us.
talking with someone from another group, and he uses hunter socks, which are battery-operated socks that keep your feet warm in the coldest weather. You can get them at LLB.
You can get gloves too,
Yeah.
not just
Are
socks,
they?
gloves.
Is that like that the hunters wear or?
Yeah.
Okay. That's a good idea too. They have some other kind of little hand warmer things you can stick down in your gloves or in your socks, you know, that are good also. That could be helpful. So I think all of those things, all of those suggestions are really appropriate, helpful.
Thank you. Well, I have a couple things yet I've forgotten to tell you all. Of course, I'm trying to get people more interested in books. And so this was a good book. Apparently, it was sent out by the polio communication newsletters. It says How the New Science of Gratitude Can Make You Happier, and by Dr. Robert Emmons. And it tells about how your positive attitude helps, make you feel better. And then there's also a thing that I read that PHI has signed an agreement with the University of Massachusetts Amherst for PHI to do archives on polio. And actually, we've discussed around here how we should save our history for the past and find some place like this for our history, like when we have our meetings, what kind of things we do in our publications. And Carol and I have thought about it, and maybe, might be useful in the future to work on something like that.
I know one of the things that we used to do is have a book review, some kind of book activity. And so having a book discussion, like a book club type of thing, might be helpful and interesting to the group.
These are all things, for next year, for our programs. So there's a lot going on, because, our young people would like to know what happened to us as part of the studies on polio and maybe more things that are going on internationally.
You to have a movie and once a year, similar to the one that we had this past year that seemed to go over very well and people enjoyed that. And maybe we'll have popcorn next time. But that was an eye opener. I thought a really good movie. A couple of points in there were not accurate, as we said, but overall the movie was very good about a polio survivor. So I'd like to do something like that. It'd be good if we could have an author like Dr. Bruno come in again also and present their findings to us. That would be very good. What else do you have? Let me see. Trying to make sure I haven't missed anything. Looking back at my phone, that's why it's taking me a minute.
Anyway, I hope all of you show up for our Christmas party so we can have a happy time enjoying, get a start of the holidays and have a nice sing-along, enjoy good food and good companionship. And
If you so choose, is that in the month of October, we usually do something in October, September, October around Medicare, which is really good too. But it's also Polio Awareness Month and World Polio Day, October the 24th. And so this group could choose to do something around that time, if they so desire. And, you know, the CDC has a lot going on. I've been involved with the CDC, and people have been interested in doing something along that line also. So, anything else? To the group? Gee, this group is quiet today. Yes, Leslie. Oh, snap.
I just sent that, memorandum of understanding.
Could you talk into the mic, please? So we can catch this for the.
I got
Turn it on.
top at the top.
Okay. I just sent the memorandum of understanding that FODAC requires for us to have a partnership and start that. And she said, Lori Ann, who is the director over there at FODAC, she said that she thought it was really, really good. She was giving it to Chris Brand. So basically where we are with that is that we're waiting for that to come back. And the application needs a little work to go online. I don't know how we do that here. Who puts it on our website? Who's in charge? Oh, okay. So, who do I mean, if we all agree, the people that are on the committee, if we agree, do I just send it to Alice or what? I don't know. Somebody has to tell me. I'm just the person writing it all and doing that stuff. Somebody has to tell me how to deliver it to some place. So we can have that actually start pretty soon?
Yes.
Like really soon. As soon as she comes back and says he approves it, so then we could really be going.
We need to be ready to go.
Yeah.
Yes, we need to be ready to
See
go.
what our response, and then advertise it on the, somehow we could send out maybe a special email or notice
Yes.
or something to our members.
We'll send out an email, I think, probably to the members.
Once it's on the website.
Yeah.
Right.
And so they don't
There you
know.
go. So they can go there and see, explore, get an idea. Okay. All right.
Okay.
Special Needs Assistance Fund. Remember, I do believe that Georgia Gives has something to do with that fund, right?
I'm sorry.
Does Georgia Gives have something to do with the staff fund? Yes?
We should be. Yeah.
So the more we do that, the better we are. So,
The monies
right.
generated from Georgia Gives are designated for.
Designated for SNAP. That's how I
Right.
understood it, but
Yeah.
I don't have, I'm not good at all the
Right.
words and all that. No, but that's how I understood it. So I know that's a big deal, and I've sent my notice out to my friends and relatives and everything. So
Great.
that will be very helpful for our fund, because the more people who start to access that, we're going to have a need to replenish it, and that's a great, easy way to do that.
Yeah, that's a great partnership
Yes,
too,
it
so
is.
thank
Yeah.
you. Yeah.
Okay? All
Thank
right.
Vicki for bringing that up.
Yes,
That's
ma'am.
very true. So, it looks like that to the board, to the members I spoke to the board, at our last board meeting. We're gonna have another little mini meeting, before we meet again in January. But for those of you that don't know, I'm stepping down as, president of the board. Because of all the activities that's going on in my personal life. But I'm here to be supportive also of the board. Will serve as an advisor and still be there, but not quite to the degree that I was. So I just want to thank you. There'll be an official notice going out to folks. So we'll probably put it in our newsletter and make sure that everybody has that. To the board members especially, thank you for your support during the years that I've served. I really appreciate it. And to all the members and attendees for your support in these activities, I really appreciate it. And Allison, thank you for just being here to help make these things happen and publish us on the website. So, if there's no further ado, Rita?
Yeah, that's it, and of course, I walk in and I see Alice, and that's it, all my stress level goes down. So thank you, Allison.
Shall we
That's it.
adjourn this meeting? We'll adjourn early.
Yeah.
Thank you all for coming.